Thank you, sir. You all have been bearing up with me quite well. We'll see how this goes here. 20 questions here with explanations along with them. So first question here. These recordings were made from a 60-year-old man with dyspnea at the time of his hospitalization. What is the cause of the wide complexes? Okay. We need to go back a little bit here because that's the explanation slide up there. Okay, here we are. Is this ventricular tachycardia, atrial tach with aberration, atrial tach with pre-excitation, or more information is needed? Okay, you guys are better than my crowd is here. Parenthetically, I put in this more information is needed option here because when I was making the questions for our exam, there are some things where you don't need more information and there is a definite answer, and some where you just do, and you shouldn't make a call without that. So sometimes that is the correct answer. But here, the correct answer is atrial tachycardia with aberration. And you see the justification here for it. This episode starts with a premature atrial complex. So most ventricular arrhythmias, if there's an A in front of it, that's just a coincidence. But a supraventricular with aberration has to start with an atrial complex. And we have a subsequent narrow complex over here that starts with a similarly coupled PAC. So we know the patient has PACs, and here's another one here. And then the P waves precede the next couple of QRS complexes like that along the way. There's not one following the last one. So if this were VT, and it has a one-to-one VA relationship along in here. Why didn't it have a P wave at the end there? So this is supraventricular with aberration. It's a little bit of a funny pattern to it, but sorry, it is aberration.
Would you call that Ashman phenomenon?
Well, yes, the long short. What Ashman described and what the purists say is during atrial fibrillation, but the physiology is the same. The long short interval, that's a good point there, Joe. Okay, we'll move on to our next one here. There's several points to this one here. This is a 39-year-old man with multiple trauma and has this tracing here. Nurse thinks she was suctioning at the time, not real sure. What should you do? Either order atropine before each suctioning that comes along the way, start dopamine, place a temporary pacemaker, put a sheath in just in case you might need a temporary pacemaker, or just continue monitoring. It'd be handy to have that ECG up there.
Break down, come on.
It's kind of hard to remember what that ECG looked like, but you got it anyway. God, you guys are good. Wow. All right. What we should do here is continue monitoring because what you see on this is this pretty flat line along in here, and then this little ripple here that suggests that there might be a QRS that's trying to be there. Same thing here that times exactly with the QRS. And if you do the magic of PowerPoint and take these 3 beats up here and superimpose them here, oh, it just is perfect. And the same thing down here. It's exactly where it should be. And so that flat line is a little bit too flat to be physiologic. There clearly is artifact occurring at other times along the way. It's not just a perfectly nice, smooth tracing, and then all of a sudden this stuff happens. So this is artifact, and we need to keep monitoring, and the suctioning, whether it was present or not, had nothing to do with it.
Yeah, let me just mention that I think that artifact is considered to be one of the things that they're particularly interested on the board exam.
Is it really?
That you can tell the difference between artifact and rhythm. So every time you see a rhythm or a tracing, one of the things that should kind of pop to mind is this real or is this not real?
Yeah. We get bothered by this quite a lot because somebody has what looks like a prolonged pause and they get a pacemaker when it was, not a real pause, or a defibrillator for some non-sustained artifact on the ECG. Okay, another tracing here. This is an unconscious patient who had a motor vehicle accident. Chest film is there for you. And it's a very simple question. What kind of device does he have? I'm not looking for manufacturer. I'm looking for, is it a dual chamber pacemaker, a biventricular pacemaker, dual chamber defibrillator, biventricular defibrillator, or a single chamber ICD? Dual chamber ICD, boy, I just wish I could take you all home and be my fellows as well. This is pretty good. Okay, what we see here is it is a dual chamber ICD. Without a comparative film of somebody with a pacemaker, you can't say, well, this is large or it's small here. It's a relatively large battery here. The key here is that it's got a very thick lead. This is the proximal shocking coil and the distal shocking coil. Everybody has a distal shocking coil. The manufacturers make leads that don't have a proximal. Most guys, most of the implanters nowadays go with a single distal coil. There had been some enthusiasm years ago that the proximal made a different vector for your shock, and you can program this non-invasively, and it might make for a little bit lower defibrillation threshold. It doesn't do that much, but what it does do, it makes it much harder to extract this lead if it causes a problem, because adhesion occurs between the SVC coil and the SVC. So most will go with a single coil, and it will always be a distal coil. Now, we have a two-chamber here. It's not a single chamber because there's an atrial lead hanging out over here. And it's not biventricular because you don't see another lead coming out here, and you don't see a lead coming off towards the coronary sinus and left ventricular. Those are very small leads. Sometimes they don't show up very well in an underpenetrated film. And it's sometimes difficult to count the number of things coming out of a header here. These are changing as well. Sometimes you'll have a dual chamber defibrillator with what looks like only two wires coming out of it, because the defibrillator lead in this case is one lead here, but it's got four different elements to it. It's got a distal electrode, pacing electrode, a proximal pacing electrode, a distal coil, and a proximal coil. So the pacing electrodes go into one wire, so this thing trifurcates up here, looks like a trident, and one is a distal coil, one's a proximal coil, one's a pace sense lead, and then the atrial lead goes in here. Now, newer defibrillators have a 4-in line, so they have all the pacing functions and the shocking functions on one thing that you stick into the header. So you may have a different count of actual wires going into the thing in subsequent years. Okay? So there's the atrial lead there with the green arrow. It's sometimes not so easy to see. And the ventricular distal coil and the proximal coil. All right, question number 4. This recording was in a 91-year-old man with bowel obstruction. What's the cause of the wide complexes in the middle? Ventricular tachycardia, atrial tachycardia with aberration, AV nodal reentry with aberration, atrial tachycardia with pre-excitation, Wolff-Parkinson-White. Doing great, just doing great. All right, this is an example of VT, and I find quite often that, especially in our house staff, they miss this sort of thing. I think not because they don't know the criteria, but they're maybe applying them wrong, or they just don't want their patient to have this disorder. But let's look at this here. This person starts out with relatively poor AV conduction, this is lead V1, so this is a left bundle branch block pattern here. They come along here. First of all, there's no P wave that we can see in this lead. We can see it pretty well during sinus beats. We can't see any P wave that occurs prior to the first wide complex rhythm. So that's a little bit of a clue that it might not be supraventricular. Second, this is the rate of this wide complex stuff is pretty fast. Could AV conduction be that fast when it's that poor during sinus rhythm? And by the way, over here, towards the end, we have a non-conducted P wave, very long PR, non-conducted P wave. So it'd be really, really unusual for an atrial attack to be going along in the middle here, with conduction so much better than it is during sinus. Okay, so we got two problems already. We got conduction faster than it should be able to. We got a wide complex rhythm that starts not with a P wave, but with a QRS complex. And the third, and the real killer problem here is, if you think about it for a second, if you got left bundle branch block to begin with, and then you come along with right bundle branch block aberration, you block the right bundle, what do you got? A bunch of P waves. You don't got no conduction. So if you have opposite directions of bundle branch block occurring, one of them is not conducted. One of them is ventricular in origin. So we got lots of ways for this to be ventricular tachycardia, and you got it right.
Do you think that fourth beat might be a fusion beat?
The fourth one, well, like the thing doesn't show up on this one, like there, you mean? Oh, the first beat in the run. Well, it could be, except that this one here, yeah. I don't think so. It doesn't look exactly the same as the rest of the VT beats, but in order for it to be fusion, there does have to be a P wave in front of it. There does have to be some degree of conduction. And the P wave that should be occurring there is going to be occurring just about at the onset, if it's a sinus rhythm. It should be occurring just at about at the onset of that QRS. So it's a good thought. I just don't think it's probably correct in this situation. Parenthetically, when doing ventricular stimulation in the lab from the right ventricle, and we're giving 8 beats of pacing and then a premature beat, the premature beat almost never looks the same as the 8 beats that we're proceeding at, even though we're pacing from the same side. That's because the heart's in a different position in the chest, different filling patterns and stuff like that. So the first beat before it gets stabilized out, the first beat or two may not look quite exactly the same. That's a good point. Okay, question number 5. A 34-year-old man is admitted with endocarditis and is on long-term antibiotics. He begins having this rhythm, and he has a chest film that is shown on the next slide. So let's just look at this rhythm here for a second. And I would call this sinus rhythm with some movement a little bit here of the leads, and then a burst of wide complex sinus, a burst of wide complex, and it just keeps going on and off. And the wide complex stuff, this is leads 1, 2, and V1, it looks like. So it's a left bundle, left superior, okay? And this is his chest x-ray. Not too much going on there. And you see he's got a PIC line here. It's coming in from the left arm, going around over there. And so the question is, with all of this put together here, what is the rhythm diagnosis? Is it pre-excited atrial fibrillation? Is it a benign ventricular tachycardia? Is it ventricular tachycardia due to the abscess, due to an abscess with endocarditis? Or is it tickling of the ventricle by a PIC line that is too far in? Pretty good. Well, this is really good because you really can't even see this PIC line. But if you look at the ECG here, there's some funny business here. Most ventricular tachycardia that is this monomorphic is relatively regular. This stuff is just all over the place. It has this long pause in here and then starts up again. It's not artifact. It's very clearly not artifacts. It's a clean tracing otherwise, so it's not that I should have maybe put that as a distractor maybe. But this guy doesn't have pre-excitation during sinus rhythm. Why should he all of a sudden develop it here? That'd be really unusual. And there's no P wave that initiates this business in any of these tracings, so pre-excited anything or atrial fibrillation would be very unusual. Abscesses can cause heart block. I've never actually seen an abscess cause a ventricular arrhythmia. I guess it could. But PICC lines and other lines, dialysis catheters can do this as well. They don't usually cause atrial arrhythmias, although they can. If you think about it, the way one of these catheters comes in to the atrium, the SVC funnels open, so something dropping in from the right or the left, it has a hard time hitting the lateral wall of the right atrium. It hit the floor of the right atrium, I suppose. But this has actually gone into the ventricle. And the reason it's irregular is that there's a normal contraction of the ventricle, and then just mechanical irritation with the tip of this catheter on the ventricle, and then that causes a contraction that then causes it to hit it again. And so you can get this very erratic, very rapid-looking stuff with mechanical irritation. Swan-Ganz catheter is not as likely to do this unless it's pulled back out of the pulmonary arteries and is tickling the right ventricular outflow tract. And when I have some arrows here that show the course of the PICC line that's just a little bit too far in, and usually they measure this thing quite well and so forth. Not this case. Any comment, Mr. Chairman? No?
No,
I think you guys probably
convincing.
see this more than we do. And it is a transient phenomenon. Somebody's putting in a PICC line, somebody knows I just pull it back, or you're putting in a PA catheter and you see this and pull it back, and it's just not an issue. But in this guy, it was quite vexing for the team. So he doesn't need a big workup for ventricular arrhythmias. He needs to have his PICC pulled back a little bit. All right, we're a quarter of the way through here. A 44-year-old woman is under observation after an overdose of a lot of different prescription medicines. Don't know what they were. A monitor strip shows what you see below and what should you do next. Continue observation. It's Obamacare. We don't have too many resources left anymore, so maybe that's what you should do. Well, it does say VFib, VTAC down here. It's kind of hard to ignore. Insert a temporary transvenous pacemaker. Give atropine, isoproterenol, amiodarone, or magnesium. I was quite confident you would get this correct, and you did. This is another artifact coming along the way here. It's not a bad artifact. It's respectable, but it's still an artifact nonetheless. And there are a couple of clues here. One is the pulse tracing. It's kind of hard to have that nice, even, and robust a pulse tracing during ventricular fibrillation. Just never see that. And the second is that we've got you can sort of march through QRS complex. There's a little dingle there, and so forth. If you do it very carefully, you can. That's not always possible. Sometimes the artifact is so big that it just overwhelms everything else. And sometimes it's a matter of changing a lead or looking at two leads at once. Since I submitted these slides, I had a beautiful tracing from one of our hospitals of 3 leads of monitoring, 3 simultaneous leads. The top lead looked just fine. It was a dual chamber device of some sort, pacing and just fine. The middle lead looked like atrial flutter because it looked like something that was atrial amplitude. And in the bottom lead, that same artifact looked like ventricular flutter. So it looked like 3 simultaneous things going on, which of course can't happen.
So in general, on an exam, they have to give you evidence on the tracing that's unequivocal that it's artifact.
Yes.
So they're going to show you an arterial line like this, or one of the leads that's simultaneous will have a regular rhythm, or you'll be able to march the rhythm right through the artifact.
Yeah,
So
it'll have to be fair, and it's something that if you look at it carefully, you can get. Okay, next one here. A 55-year-old man found down with several empty vodka bottles nearby. Maybe vodka's a clue here, who knows? Blood pressure is not so grand. As ECG is shown, what should you do next? Should you cardiovert him, administer IV amiodarone, administer IV magnesium, or administer IV calcium? Aha, caught you. It would not be wrong to cardiovert this guy, since he's doing not so grand right now, but this is not ventricular tachycardia. And somebody who is going, this is barely even a tachycardia at this point, it's about 115 a minute. To have this bad a blood pressure due to VT, they've got a lot more problems than, the rhythm is not the problem here. The problem in this case is hyperkalemia. And the hallmarks of this are typically the wider your QRS complex, the longer the QT interval. Longer depolarization leads to longer repolarization. And it's just not so much the case here. If you look out in for instance, the inferior leads or in the lateral precordial leads, it's a pretty narrow T wave and it ends pretty quickly. So there's something funny about that. And hyperkalemia shortens repolarization. Low potassium prolongs repolarization. So does low calcium. But low potassium prolongs repolarization and hyperkalemia does the opposite. So you see these kind of peaky T waves here. A QRS complex that's wide, diffusely wide, and just kind of, there's no ST segment, just kind of goes right into a T wave that's relatively narrow. P waves are kind of splayed out. What high potassium does is decreases the resting membrane potential that deactivates some of the sodium channels, so not all of them are operative, and they're not all functioning very well, the ones that are operative. So sodium channel depolarization or opening gives you the rapid upstroke of the QRS and P waves. The sum of all these cells going is the QRS complex or the P wave. Now, if you make all those cells go slower in their depolarization and cell-cell conduction slower, you just stretch out the QRS complex, stretch out the P wave. So there may be sinus rhythm here or atrial arrhythmia or something. You can't see P waves on it because they're just all stretched out too much. And you stretch this out even more and you get a sine wave because the QRS just melds into the ST segment. Now, most examples that I have of this, I'm glad to say I don't have too many examples, are of a left bundle pattern. The left bundle is a little bit more sensitive to potassium than the right bundle, but this is an example of what looks like a right bundle branch block here. And it's important to recognize this. You see dialysis people all the time. This guy has rhabdomyolysis. Basically, he's been laying around too much with his empty vodka bottles.
So this is a favorite for the both practice and regular examination, so you should get familiar with hyperkalemia. And you commonly are thinking that it's ventricular tachycardia, but it's hyperkalemia, and you're supposed to treat it with calcium as in this question. So this is a good one. Kind of keep it in mind.
Yeah. Now, this doesn't usually develop on you, right? It's somebody who comes into the ER with this. You're consulted to go down to the ER and take over care of this individual. Somebody comes in missing a couple of dialyses or a multiple trauma like this for an outside hospital.
That's how it usually is.
Yeah, and it's not somebody who's been in the ICU for a couple of days and then develops this. You're onto that. So it's somebody who you're seeing for the first time, most likely. Okay. Question 8. A 39-year-old man on chronic dialysis, speaking of dialysis, comes to the hospital with palpitations and has the attached ECG. What is the likeliest diagnosis? Now, the fact that I just showed you a hyperkalemia does not mean that this could not possibly be hyperkalemia. But on the exam, they are a little bit more mixed up than that. Mixed up in a lot of ways, I guess. So is this sinus tach with pre-excitation, Wolff-Parkinson-White? Is it sinus tach with aberration? It's not very fast, but it's just a little tachycardia. Is it ventricular tachycardia, or is, again, a drug or electrolyte abnormality present? Okay, you guys are fading a little bit here. All right, well, let's look at our tracing again here. And if it's a drug or electrolyte abnormality causing the wide QRSs, what happens with these? How come you get these narrow ones in the midst there? Do they all of a sudden not have hyperkalemia or procainamide toxicity? That'd be pretty unusual. Wolff-Parkinson-White is not a bad choice at all here because we see a short PR and slurred upstroke and all that kind of stuff over here. That's pretty nice. But then we have a problem with why we have these narrow beats in there, and then it starts up again. But the real problem with Wolff-Parkinson-White occurs off on the right side over here, where we have QRSs without any P wave in front of them. On the V1 rhythm strip, we have P waves and QRSs on the far left. That's fine. And then we have QRSs without any P wave in front of it. Well, how does that work? So this is not an atrial, it's not sinus tach with aberration. It's not sinus tach with pre-excitation. It's not a drug or electrolyte abnormality. So it is just ventricular tachycardia. And it kind of looks like WPW. I'm not going to fault anybody for that on the left side, but as it develops along the way, and this is why you're always instructed to look at all the information. When I was writing exam questions, we tried to pare down the question to just the essential information, not a lot of distraction along the way. When Dr. Zimmerman was showing you slides, she's got what you need to see for the PT and the PTT and the platelet count, and not what the serum preduodenum level was or something like that. So if you look also at the 12-lead pattern here, it is not one that would be typically associated with aberration. We didn't go over too many of these during my earlier discussion. But V1 looks like kind of a monophasic R wave. That's just not what you see with normal right bundle aberration. You see a little R wave and then an S, and then the right rabbit ear greater than left. Out in V6, with typical right bundle branch block, because the right ventricle, with right bundle branch block, it's a smaller voltage mass than the left ventricle, so its contribution is going away from lead V6. It's an S wave, but it's a small S wave. And so it's just displaced late in the QRS. So you have a large R, small s, RS ratio greater than 1 with aberration. We don't see that here. What we see is a small R and a deep S. And that is because this is coming from the left ventricle, so all of the right ventricle voltage is going away from lead V6, plus some left ventricular voltage going away from it. And so that's why the RS ratio less than 1 in lead V6 is a reasonably good indicator of that as well. And as I said earlier, a drug or electrolyte abnormality will not explain why there's some wide and some narrow QRSs along the way. Okay? Good. So there's the P wave present in front of one of these QRSs, and the P wave, not a QRS without an antecedent P wave associated with it, and then there are those narrow complexes there. All right. What is this rhythm? Sinus with left bundle branch block conduction, sinus with pre-excitation, and we didn't talk about a Maheim fiber. Nobody likes to use that term anyway. It's a slowly conducting accessory pathway that gives rise to a left bundle branch block pattern. Sinus with tract ventricular pacing, or sinus rhythm and demand ventricular pacing along the way. Okay, this would not be a bad answer, except that it is incorrect. And the reasons it's incorrect is because there are really, really tiny pacing spikes on here. And you have to look kind of carefully for them. I don't think I have a magnified view of this. Sometimes I'll put one of those up here. But you can see, especially in V4 on your book, I think it is nice little pacing spikes in front of those guys here. And I think in lead 3 as well, off over here. And so it's pacing. It's not one of these other guys here. And as I was looking at this yesterday, I realized that I don't like this too well as a question because there's this little pause in here, and if it were really ventricular pacing, just sinus rhythm going along, but with ventricular demand pacing, like a VVI, ventricular pacing, ventricular sensing inhibited, then you should see a perfectly regular ventricular rate here. So I'm embarrassed that I put in a question that doesn't have the most obvious answer here. It is clearly sinus rhythm going on here. I don't believe it's tracked ventricular pacing, because why should this AV interval suddenly increase here? But the RRs are not perfectly regular here, and I'm not sure. I will not show this one again with this answer anyway. It's supposed to be, if you have a constant RR interval, irrespective of what's going on in the atrium, then the atria are not being sensed, either because there's no atrial lead or it's not programmed that way. Okay, I want to get past this one because it's embarrassing to me. But there are the stimulus artifacts.
Well, everybody gets credit for
Everybody gets credit for that one, yeah.
Okay.
Except for the people that voted for, for conduction. All right, now, what is this one here? 3 leads here. A V1 lead on top, a lead 2, and then a V5. Is got a 1 in 3 chance here. Supraventricular with aberration, VT, or pacemaker-mediated tachycardia. Ooh, you guys are getting back on your game here. All right. This is SVT with aberration, and let's dissect this out here a little bit. We have sinus rhythm up here coming along, and you notice there's a little bit of an incomplete right bundle here. It's not a complete right bundle, so I'm going to have to spot you a little bit on that. We have some PACs that conduct with a relatively narrow QRS, and then it gets wide over here. And we have P waves that occur up, got some lines here, I think. Where are they? Yeah, so there's P waves along there. This is a little burst of atrial tachycardia. And this is a little tricky here on a couple of fronts. First is we have what looks like left bundle pattern here, and we had this right bundle. I just got through telling you that if you got right bundle to begin with and then go to left bundle, it's 2 different rhythms. Here's an exception. It's an incomplete right bundle. It's not really a conduction system problem. It's a muscle problem in this patient. And so his Purkinje system is just fine on the right side. But it blocks in the left bundle, comes out there. The other problem with the other objection to aberration is we've got our long short interval here, right? So why does this suddenly fail to conduct in the left bundle? Okay, that's a legitimate thing. But then we have these P waves up here, and if this were ventricular tachycardia, how come it starts with a P wave? How come if there's a 1-to-1 relationship, why don't we have a P wave after the last one here? And we clearly don't. So, and there are no pacing spikes anywhere along the way for it to be a pacemaker-mediated tachycardia. It probably wouldn't go this fast anyway with a pacemaker tracking. So this is a tricky one, and I trip up my fellows on this pretty routinely, so don't feel too badly about this. Okay, this gets close to home here. A 56-year-old intensivist comes to work, and he's starting to have chest tightness and palpitations, and a little bit of lightheadedness, and says, you know, can somebody just hook me up and see what's going on? So he's hooked up to an ECG, and this is recorded. So what do? Told him to quit playing games. On my neurology rotation as an intern, we had a resident who was kind of snarky, and so the last day of the rotation, I took some eye drops and dilated one of my pupils. I got right up in her face and said, man, I got this terrible headache. I'm looking right at her, and she goes, it, got her. But so this guy, stop fiddling with your wires. It's not funny. Give him amiodarone, give him magnesium or Cardivert if you like him, if he's a good colleague, and call the cath lab. Yes, okay, this is something that really, you can make a big difference for these folks here. Obviously, you have to cardiovert him first, but this is a lot of ST elevation going on here. And if we can get to our slides. Okay, a lot of ST elevation. And in the V leads, this is an anterior infarction here, and he's got a PVC that occurs on the ST segment on the T wave. This is an R on T phenomenon, and this received much attention back in the 70s with the beginning of coronary care unit monitoring. And the R on T gets a lot more credit than is really due. This is the setting in which it has relevance for the most part. Lots of people having PVCs on their T waves, and we're not seeing a lot of dead people because of that. But this is the setting: peri-infarct ischemia, fresh infarction. A PVC on that T wave can hit areas that are sick and not repolarizing well. Other areas that are repolarizing reasonably well, and end up with this polymorphic VT. This is not torsade by its strictest definition. That is a long QT, drug-related polymorphic VT. This is a normal QT, not drug-related, and is ischemia mediated. So treatment is very different.
So noticing that you have ST segment elevation anteriorly is kind of really the key there.
Yep.
And the audience did very well. Impressive.
And this is a relatively, this is almost hyperacute T waves here, going right up into the ST segment. And give it another 15 minutes, and it'll look more like a STEMI. But this is the time to intervene on your colleague here. Okay, you did very well on that one. All right. On this one, what is the rhythm diagnosis? I'm sorry the tracing is pretty faint here. I hope it's not that bad on your materials. Okay, the majority say ventricular tachycardia. I'm going to go with the majority here. There are several ways of looking at this here. We'll just go through some of these here. The morphology criteria in lead V1 and V6 are very much in favor of VT. We also have in the rhythm strip, you can see with the dark blue arrows here, where there are P waves, the light blue arrows is where one would be if you march it out. You can't see it because the QRS or the T wave is superimposed on it. And sometimes it's something as subtle as like this T wave in lead 2, it's peakier than its brothers. Well, why is that? Well, it could be artifact, but it could be a P wave, a sinus P wave piled on top of it, which is what it is. And if you can march those out, you've got a pretty good clue what's going on. Now, V1 has this funny pattern to it. It's kind of a tall R and then a little dingle of an S wave. And I tell my trainees that you look at the last half of the QRS in V1 to tell you what bundle branch you're dealing with. If it's going away from, if it's negative in lead 1, it's going away from V1, that means it's a left bundle branch block. If it's going towards V1 in the last half of the QRS, the right ventricle is late, it's right bundle branch block. Well, what is this? Because the most of the QRS there in lead V1 is positive. You'd say, well, okay, it's right bundle branch block pattern. But the end of it is going negative here. So what is this? It doesn't know what it is. If it doesn't know what it is, it's neither right nor left bundle, and it's likely to be ventricular in origin. So that's an RS, tall R, deep S, and or tall R, small S in lead V1. Now let's look at a V6 here. Boy, there's RS ratio is way, way low here. There's actually not much of an R wave there to begin with, so that would be very unusual with aberration. You got to be a little careful with the morphology criteria because those sort of, to a degree, depend on what the baseline QRS looks like. And as folks are getting better treatment for their heart failure and living longer, we're ending up with some pretty weird-looking baseline QRS complexes. Adult congenital heart disease, a burgeoning population of individuals there with some really funny-looking QRS complexes. So when they go wide on you, it can look pretty funny during wide complex and still be supraventricular. Now, this can't be biventricular pacing because we don't see any pacing spikes. You don't always see them really well. We just saw an example of that where a lot of us were fooled into thinking that there is no pacemaker. But in 12 leads, no pacing spikes, really? It'd be a little bit odd for that, and to be going this fast with biventricular pacing. Pretty wide QRS, you'd say this is not very good narrowing of the QRS by biventricular pacing. Okay, all right, question 13. 79-year-old with prior valve surgery. You can see the valve in here. It's a mitral valve. You see it opened up in profile there, mitral valve ring. And a pacemaker had syncope and a fall, and she fractured something in her shoulder or something. This is her chest film. What test do you order now? Coronary arteriography, right heart cath, pacemaker interrogation, two-dimensional echo, or transesophageal echo? Pacemaker interrogation. Now, you order this anyway, right? So this is kind of a dumb question in some regards. Far more than is necessary, pacemaker or ICD interrogation is sought. Somebody comes in to the ER after a traffic accident, their left leg is missing because of trauma, and they got 16 broken bones here and a subdural, but let's interrogate the pacemaker. Really? The rhythm is fine and everything. But in this case, there's problems. And this pacemaker lead is fractured. It is fractured at a point where most pacing leads are most vulnerable, where it goes underneath the clavicle. And to an extent, this is a problem with how the device is put in. You don't have anything to do with that. It's not your problem. But in this case, it was probably put in with a subclavian stick here, and that typically goes through the clavicular ligament there, the cervicoclavicular ligament, and ends up being squeezed off. It's a point of tension or rubbing between the clavicle and rib there. And this is a technique problem. If you stick axillary further out here when you're implanting this device, it goes much deeper and it doesn't end up going through that ligament there where they kind of give that scissoring action. This device is, in this particular person, had probably been in for, I think, 8 years or so. And all of a sudden it just said, okay, I'm done with it. Now, be careful about this because what we see here is two things. One is a discontinuity in the shadow here. It's white and then it gets kind of dim right in the middle where my pointer is. And the other thing is it's a very sharp angle. There should be a nice smooth angle, nice smooth curve. And there will be times when you'll see a discontinuity in what it looks like discontinuity in the metal of a lead and think, oh, is there a fracture there? It just has to do with how much insulation is around it and what the components of the insulation as well, whether there's a shocking coil or some other mechanism around it. Pacing leads tend to be pretty uniform all the way down. Defibrillation leads not so much. So you can see what looks like a discontinuity in the metal somewhere along the way, and it really isn't. It's functioning just fine. But in this case, you'd see that something is wrong with the pacemaker. Now, importantly, it may be functioning just fine right now. On the ECG, it may look just fine. And you may get an interrogation, and everything looks good at the moment of interrogation. But most devices nowadays will have an impedance trend or something that says we had a spike in the impedance that's with a lead fracture Sometimes you can manipulate, or the electrophysiologist, whoever's interrogating, can just kind of poke around in this area here and reproduce the problem. And this patient needs a new wire. Now, the echo is not going to help you in much regard. A lot of those get ordered as well for not much reason. Syncope and two-dimensional echo don't really go together in the same sentence in most cases without a physical exam in the midst. Somebody's got severe aortic stenosis, okay, on exam, that you think they've got severe aortic stenosis, and echo and syncope kind of go together. But somebody who's just had syncope without any antecedent symptoms and their exam doesn't show anything, echo is not going to show much of anything. And a paradoxical embolus has no relevance with syncope here. Okay, so there's our lead fracture up there. You guys were all over that. All right, 68-year-old woman is admitted with respiratory failure and we don't quite know what her volume status is, and it's determined that she needs a PA catheter, and her ECG is shown. Of what things should you be worried while placing the catheter? Initiating a supraventricular arrhythmia, initiating a ventricular arrhythmia, causing complete heart block, or perforating the ventricle. Okay, causing heart block. This is somebody who's got baseline left bundle branch block, and you're going to be putting something that's going to be traversing their right ventricular outflow tract, kind of where the right bundle hangs out. Anybody who's got left bundle branch block has some vulnerability to their His-Purkinje system, and it's kind of it's something you don't want to really encounter at 2 in the morning. Somebody who has one problem, they're sick enough to call you in for a PA catheter, and now they've got another problem, complete heart block. And I've seen this not just with a catheter that's intended to be in the right ventricle, but I've actually seen it with a guide wire, either from the right subclavian or the right IJs. Right subclavian is probably more prone to this because the guide wire, you're just putting in a central line, not putting in a PA catheter, putting in a central line and getting the guide wire in there, and it comes along, sweeps along the septal aspect and runs right into the right bundle if you're unlucky. And I've seen, people say, hey, I'm just putting in a central line, there's not going to be a problem here, and it certainly can. So if you're putting in a central line, be careful where that, especially without fluoro, be careful how far the J wire goes in. Okay, SVT could happen, and but the angle of the dangle is not good for, not very favorable for getting supraventricular arrhythmias when putting in a PA catheter. PVCs, short runs of VT, yeah, we're all familiar with that, not much of a big deal. Just pull back and reposition.
Yeah, in this situation, would you suggest putting in a PA catheter with fluoro? So if you had to put in a temporary pacemaker, you could put that in easily too? I
think so, and certainly if the individual is very, very ill and you think, boy, if this person goes into heart block, we're going to be in the deep tundra pretty quickly, then I think either having a second sheath in or a temporary pacing wire nearby and doing it under fluoro is a very, very good idea. And putting it in from the leg is putting in a central line from the leg, if you do that, that's okay. A guide wire is not going to cause that, but putting in a PA catheter from the leg doesn't help you at all with this particular problem. Okay, this is 2 leads of monitoring here. We got a lead 2 on the top and a lead V something. I suppose it's a V1. It looks like a right precordial lead. And the question is, what is the likeliest diagnosis of the arrhythmia shown? This goes back to way back earlier this morning when we were talking about this stuff. Typical AV nodal reentry, atypical AV nodal reentry, focal atrial tachycardia, or orthodromic tachycardia related to bypass tract. And I gotta say, I can't imagine you'd be asked this question on the exam. I don't think you need this degree of granularity. Well, I'm not too upset about this. That is not the correct answer. One of those is the correct answer, but not AV nodal reentry. Now, why is this the case here? Well, if we look at our tracing, we see we have a sinus beat at the far left, and then the first thing you see that starts things off is a positive P wave in the inferior leads. The AV nodal reentry is not typically going to start off with the first beat being the tachycardia. It needs a premature beat. Okay, that's a premature beat, but it's not got a long PR to it. And we have to block in the fast, go down the slow. So that's a little bit unusual. So it's positive in that lead, and then it continues as being, continues being upright throughout the rest of the tracing here. All the rest of these P waves are upright. And if you look at the, where this kind of almost looks like a very short QT interval, like a very peaky T wave, but it's not. It's the P wave over here on this part. And if you follow it on, they all look pretty similar here. But as you follow it further, those guys start peeling off of there. Now, a bypass tract, you go through the ventricle, you come up the pathway, you get a P wave. You go through the ventricle, you come up the pathway, you get a P wave every single time. And it's the same interval there. This is a varying VA interval, very unlikely to happen with an accessory pathway. So this is just an atrium that says, let's go. And the ventricle says, okay, and it comes along. And the last thing you see here is we see a P wave, QRS, P wave, QRS, no next P wave, so no next QRS. The tachycardia stops with that. So one other feature here is that a focal atrial tachycardia tends to speed up a little bit, kind of get going, and then kind of throttle back a little bit after a while. So these are all hallmarks of a focal atrial tachycardia. Again, it's just kind of a fun tracing, but to try to dissect these things out. On exams, the question writers are, I think, sensitive to, oh, this is a great question, but it'll take them 20 minutes to go through this. It can't do that. You got a time limit on your exam questions. So we've thrown out a lot of our questions in the past. It would be a great question, great thing for a lot of prolonged discussion, some teaching points, but it's just not practical to put on an exam. I think this is one of those. Okay, this is a 29-year-old with a 2-week history of chest discomfort, fever, dyspnea, and he's had enough. He's coming to the hospital. So this ECG is obtained, and what do you do next? Now, of course, a lot of this is kind of contrived because you would have examined the guy. You may have taken a little bit more history. There's probably a little bit more information here and there. But based on this, you'd get a serum potassium, maybe. You'd order an echo. You'd get a right lateral decubitus chest film. Well, why would you do that if you hadn't had a regular film? Okay. Obtain a family history of tachyarrhythmias. Okay. Now, this is sort of, well, the patient's got a heart, don't they? Why won't you get an echocardiogram? Of course. That's the second most common thing after an ECG, I think. But in this case, there are some clues here. He's got the history of chest pain, fever, dyspnea, and the thing is he's got sinus rhythm coming along here, but the QRS complex is varying from beat to beat. Not seen well in all leads, but certainly in V1, or I'm sorry, V1, V3, V4, and it's kind of going on an alternate basis. You see it a little bit in the inferior leads. I actually see this more in the inferior leads than in the precordial leads in most settings. And this is QRS alternans. It's not a great example of it. I've got another one somewhere that I couldn't get a hold of. But this is actually, if you look at an echocardiogram, the heart is swinging in the pericardial sac with a very large pericardial effusion. Now, pretty much always when you see this, it's a very large effusion. and it's not an acute effusion. They don't get that large that acutely and the patient's still doing okay. You can get a large effusion pretty quickly and they get tamponade and that's it, unless you drain it. So something that's gotten large enough to have swinging of the heart inside of it, it's pretty chronic by that time. Hemodynamics are probably not too bad. What do you think this guy's hemodynamics are at this point? He's got a sinus rate of barely 100 here. He's not in too bad a shape. If he's going 140, 150, you'd say, yeah, the guy's having problems. But he's not in too much distress at this point. And yeah, you get an echo, you drain it, so on and so forth, and send it for analysis. The rest of this stuff is kind of superfluous.
So I would say this is another favorite for the exam, the electrical alternans shown in V3 and V4. The fact that it's going up and then going down, typical of big pericardial effusion.
Yeah. The people you'll see this in are dialysis players and chemotherapy, especially leukemias where they have pericardial seeding and not doing too grand. They got a lot of problems going on. They're maybe a little bit hypotensive. They've been working on this big effusion, and but it's kind of snuck up over in the bone marrow transplant unit or the chemo unit, and then you're left to kind of pick up the pieces on the patient. So this is not somebody who has a motor vehicle accident and an aortic rupture and rupture in the pericardium. They're doing really badly very quickly. They don't have a large enough effusion. You can't get a large enough effusion to have this swinging business and still be doing okay if it's that acute. Okay, question 17 here. 29-year-old complains of chest tightness after completing his first half marathon. This ECG is shown, and based on this, what should you do? Get him going to the cath lab, get an echo, get a stress test with thallium, or get a plain chest film. Well, I probably would have done none of the above, really. But what you want to make sure this patient isn't doing, this is not a STEMI by any means. There's no ST elevation anywhere, so you wouldn't activate the cath lab for it. But it is a little suspicious that he does have these Q waves in the inferior leads and a pretty broad R wave in V1 and V2.
Okay.
And that would suggest an infraposterior infarction, and maybe he had it a few days ago and he ran the mini marathon anyway. But this is actually Wolff-Parkinson-White, and this pseudo Q wave, and I'm sure this is one of the favorites as well on the exam to fake somebody out into thinking somebody's had an infarction. But what you want to do here is make sure that this is a pseudo Q wave from a delta wave and not a real Q wave, and the way you tell that is get one of your cardiology colleagues to get an echocardiogram, and if the inferior wall is nice and thick and moving just fine, it's not an infarct. And you can't see the pathway and stuff like that, but the chest film is not going to tell you anything about what's going on here. A stress test, if you really thought it was an infarction, it might tell you something, but I think the echo is the best way to go with this. So you probably will get some questions about that would be in this neighborhood, I would think.
Yeah, so this is pre-excitation, but without any history of arrhythmias.
Right, yeah.
Right. Mm-hmm. But it's producing this pattern on the cardiogram that makes you worry about inferior
It's not an
infarction.
uncommon pattern. Posterior pathways, which is where this was in this patient, activate the ventricle from the bottom of the left ventricle, and so voltage is going away from the inferior leads, just like a Q wave does, right, at the beginning of the QRS, and activating the left ventricle first, so it gives this positive R wave in V1. It's this nice pseudo-infarct pattern. Importantly, the further away the pathway is from the sinus node, the more advantage it is for the AV node to conduct down normally. And that translates into what is the PR interval with this? Because if you've got a lot of atrium to traverse between your sinus node and the atrial muscle that is immediately adjacent to your bypass tract, then you can get to the AV node pretty fast and get down the AV node. And the PR interval may not be that short in this case. So it's a nice pseudo Q wave there. All right. 91-year-old man admitted with abdominal pain. He recently had a dual chamber pacemaker that was inserted for high-grade atrioventricular block. The nurse shows you this strip, and she says, "Doctor, this pacemaker's not working." And you say, "Pacemaker's fine. It is mode switched due to atrial flutter." Or, "The pacemaker's not working well. It's inhibited by his tremor." Or you say, "The pacemaker's fine. It likes to say battery by pacing a little bit slower every once in a while." Or you say, "Wow, great question. Why don't you look that up and tell us about it in rounds in the morning?" Okay. Now, this is pretty sophisticated stuff. I think maybe it's the least ridiculous answer on here, but you're absolutely correct with this. Pacemaker is fine. It has mode switch. Now let's look at, drill down on this just a little bit more here. Now, what's going on here is we have sinus rhythm with tract ventricular pacing all along here, and then something happens along in here. It's still pacing, so we infer that there's a more rapid atrial rhythm going on to which the device is responding by tracking along with it. It does that for a little while, and then it says, "I think I'm going to slow down here." And now we can see these flutter/fibrillation, basically flutter in there. Now, what happens with this is you wouldn't want your pacemaker going at the upper rate limit just because the atrial rate is pretty fast. And this actually was a patient who had atrial arrhythmias, and it was an elderly lady, and she had very, very rapid conduction during her atrial flutter and fibrillation, and during sinus she was just fine, but had near syncope, and I finally convinced her that the best thing for her was AVJ ablation and pacing. That's what the real story was. And so we did this, and came in the next morning, and she was having daily episodes of this stuff. She was doing a lot of herbal stuff, thinking that would get rid of her problem. She had 2 or 3 times a day episodes of this. And I came in the next morning to see her at 6:45. It's tracing at 6:40 here. Sorry, 6:45, and how you doing? "Oh, she's just as mad as a hatter. She is vexed at me because she says, 'I told you I didn't need this. I haven't had any episodes since we did this.'" Okay. I just had been out and looked at telemetry. I happened to have saved this strip for her to show to her, and said, "No, you just did have an episode, but you didn't notice it because the pacemaker took care of everything. It's very, very smooth. The rate over here is almost exactly what her rate was. Now, this rate is a characteristic rate. It's VVI at 70 or 75 or so. And what the pacemaker does is it says, aha, I see you going rapidly in the atrium. Different manufacturers have different algorithms for this. But it says, I see you going rapidly in the atrium. I'm not going to be fooled by that. I'm not going to pace every one of those, or even pace in response to every one of those, or even pace at the upper rate limit. I'm going to assume that there's an atrial arrhythmia going on, and I'm going to switch modes temporarily to ventricular demand and not bother with atrial input. And as soon as the rhythm changes back to normal, it reverts back to the dual chamber mode. Very nice system. It's been around for about 20 years or so with this innovation here. Different manufacturers do it different ways. You can adjust it to some extent how long the atrial arrhythmia has to go on before it mode switches, because if you just have something that's 2 or 3 PACs, you don't want it to jump the gun and start pacing the ventricle. Many people will feel badly when they're just ventricular pacing. This lady didn't. It's good to be able to recognize normal pacemaker function, and that we don't need to revise the pacemaker, we don't need to do any reprogramming. It's just doing fine, and you guys were all over that one. That's very good. Okay, another pacemaker question. 62-year-old man admitted with lightheaded spells. He had a pacemaker that's been around for a while and presumably doing pretty well. And these are Rythm strips, as shown. And so these occur at 4, well, the top one is 11:07 p.m. The next one is at 4:43 in the morning. Okay, so you should continue monitoring. You should defibrillate. Those are a little bit different. You should interrogate the pacemaker or obtain a chest film. Defibrillate. Great answer. Okay, well, that happens to be the correct answer. And it is correct for a couple of reasons here. One is that you can see, sorry about that. You can see in here that on this monitor lead, we're just doing fine with these dual spikes. Now, these are what I would call manufactured spikes. In other words, the actual, as I was saying earlier in the pacemaker section of our discussion, when you tell a monitor, an ambulatory monitor, Holter monitor, or a telemetry system that the patient has a pacemaker, that's code for it to say, okay, when you see something of a certain frequency, a non-physiologic, very rapid frequency, that's a pacemaker spike. Put in a marker that looks exactly like these guys here. Now, this is not what they actually look like. These are probably much bigger than if you recorded a regular EKG, an analog EKG. But you see they're all the same size, very, very programmatic that way. And when you are in this dual chamber pacing mode, everything's just fine. When you're in this rhythm here, it is one of two things. It's either artifact and you continue monitoring, or it's the real McCoy and you defibrillate. Which is it? Well, it kind of looks like the real thing, but we've seen some funny business before that looks pretty real, but isn't. And when it's funny business, the real rhythm continues on underneath, right? And you ought to be able to march that out. Well, we see dual chamber pacing spikes here, and then there, and then not again till over here, and they're pretty evident where they are. So the pacemaker is actually seeing some electrical activity of the heart, or not seeing electrical activity and pacing. So along in here, it's not seeing anything, it says, okay, I'm going to pace, and over here it does see something, it says, I'm not going to pace. So ECG artifact does not affect an implanted device. If you have a lot of external noise, arc welding or something like that, it could. This guy's not arc welding in the ICU. I think so. So this is a real ventricular arrhythmia that is either the muscle right underneath the pacing electrode has a very small signal sometimes, and it says, I don't see anything, so I'm going to pace. Other times it sees enough of a signal that it inhibits pacing. So this is the real McCoy here, and you need to defibrillate this patient. Very good. Okay, this is my last question. This is a 19-year-old with a pacemaker that has been in, he's had 3 pacemakers actually, he's had the same wires, and they just keep changing his pacemakers because he wears them out. And his present one was just placed a year ago. So he's had congenital complete heart block, pacemaker since a very small person, and he's now had 2 battery changes along the way. The most recent was a year ago. Why is the rhythm strip showing what it's showing? Pacemaker is normal, the mode is switched. Pacemaker is abnormal, it's oversensing myopotentials. Pacemaker is abnormal, it's oversensing electrical noise, or it's abnormal, it's undersensing, not oversensing. Okay. Most think it's undersensing. Undersensing causes pacing where it shouldn't occur. And that's not the real problem here. The real problem is that it's oversensing electrical noise. And you see, here is a native QRS here, and we infer what the pacemaker interval, or the inverse of that, its rate, is set at by the interval between any two consecutive spikes here. And then we work back and say, okay, that's where it's sensing this previous one. So everything's okay here so far. Everything's still pretty okay. And then we have this interval here that's fine. Why don't we have a stimulus here? Well, it's either the battery's just then died. No, it's a year-old pacemaker. That's not it. So it's either, it's oversensing something. And it's either oversensing environmental electrical noise, which you should generally be able to pick up on the ECG. And ECG is pretty okay at seeing, 60 cycle from an open circuit somewhere. Or myopotentials, that's he's moving his arm around or something like that. Where's the electrical artifact on the ECG of that? There should be motion artifact with that. So probably it is a problem with the lead. Now he's had this lead for a while. I don't tell you that he's always had the same lead, but most of these people do, and you just trick it along as long as you can until something like this happens. Pacemaker generator replacement is a very vulnerable time for leads because they are in the pocket there, they're all scarred up, and sometimes you get in there and you can feel the thing, but man, where is this? I'm dissecting around, it's just a big bucket of scar, and finally break into the scar and do some cautery. Insulation on leads doesn't like cautery so very well. So after a couple of times of this, maybe his insulation is broken a little bit, and he's getting some body fluids in and causing some arcing on his pacing leads. More likely it's a broken lead, and as he has micro movements, just respiratory movements or so, a lead that is actually the metal is fractured, but has come back together, so it makes contact most of the time, just like a lamp cord or a radio cord can have static in it. And occasionally it breaks apart and then comes back, and when it comes back together, there's a little static there. It makes a signal. The pacemaker sees that as a genuine ventricular event, says, I don't have to pace. So it waits until the next interval to pace. And so this guy has a lead fracture, and this is actually a case that ended up with a very tragic outcome. This was from a monitor, and it was read as being normal, and so the patient's caregiver said, okay, everything's normal, I guess, and he ended up having syncope and a cardiac arrest without escape and did not survive from that. That's a pretty bad outcome. So on here, I should also say that myopotentials that are from skeletal muscle they occur in everybody. You're doing vacuuming or sweeping or something like that, a lot of myopotentials. Pacemakers see signals like that if on a couple of occasions. One is if it's a unipolar sensing pacemaker. Don't use those too much nowadays. That is where to do anything, to either record a signal or pace, you have to have two poles. So what is a unipolar? Well, it's a very wide two-pole. You got a pole on the ventricular end of things with a ventricular pacemaker, and the other pole is the can of the device itself. Early pacemakers were all unipolar because it's just easier to manufacture a lead that's only one electrode. Pacing thresholds are a tiny bit less with a unipolar. It's just a lot simpler device, so batteries would last a little longer. But you did have this problem with sensing skeletal muscle voltage, which is about the same size of a signal that the ventricular muscle would have, and you end up inhibiting with that. Bipolar pacing, small spike on the ECG, it senses over a very small range. The two electrodes are right in the ventricle there, so it doesn't see myopotential. So myopotential oversensing would be a very poor cause, low likelihood of causing this problem here. So this is lead fracture. And I think with that, I am done.